Okay, so this gets us to the next question, that is question number 126. This gets us to the next question, question 126. Which of the following is most important in the bactericidal activity? And the answer is obviously B, that is peroxidase. The answer is B, that is peroxidase. This we have already seen earlier in this paper only, that is the NADPH oxidase pathway. That is the NADPH sorry, the NADPH oxidase pathway. How does it act? Oxygen is converted by, just give us a second guys. Oxygen is converted by the action of, okay, so oxygen is converted by the action of NADPH oxidase to the superoxide anion. This NADPH oxidase, superoxide anion is formed. This superoxide anion is then converted by superoxide dismutase to H2O2, which is then acted upon by myeloperoxidase and chloride, leading to the formation of hypochlorous anion. We have already seen this. So the main is peroxidase. Next, this gets us to the next question, that is question 127. Question 127. Most important complement, that is the first common point between classical and alternative pathway, C3. C3. The answer is 127. The answer is A, that is C3. So starting with the complement pathways, you very well know there are three main complement pathways. The first is the classical complement pathway. The first is the classical complement pathway. Classical complement pathway, which starts from C1, goes to C3, C5 and MAC, that is membrane attack complex. What is MAC? It is C5b to C9. C5b to C9. Next, the other two complement pathways are the mannose-lectin binding pathway, mannose-lectin binding pathway, mannose-lectin binding pathway, and the alternative pathway. The other two are the alternative and the mannose-lectin binding pathway, which converge directly on C3. Which converge directly on C3. Next, so what is the common connecting link? C3. Next point, much more important than the pathways are the deficiencies in the complement pathways. Much more important than this are the deficiencies of the complement pathways. Deficiencies of the complement pathways. First point, the most common deficiency is deficiency of C2. Most common is C2, deficiency of complement factor 2 protein, whereas most severe is the C3 deficiency. Why? Because all the complement factors, they were converging on C3, so most severe C3. Next, deficiency of early complement proteins. Deficiency of early complement proteins is associated with lupus, versus the deficiency of late complement proteins, which increases the risk of Neisseria and toxoplasmosis, versus the deficiency of late complement proteins, which increases the risk of Neisseria and toxoplasmosis. Next point, you very well know deficiency of CD55 and CD59 is PNH, paroxysmal nocturnal hemoglobinuria, and the last is C1 esterase inhibitor deficiency. Last is C1 esterase inhibitor deficiency, which is associated with hereditary angioneurotic edema, which is associated with hereditary angioneurotic edema, hereditary angioneurotic edema. This is C1 esterase inhibitor deficiency. Done. This takes care of question 127. This gets us to the next one, that is question number 128. This gets us to the next one, that is question 128. False about Libman-Sacks. Libman-Sacks endocarditis, this is obviously SLE affecting the heart, so SLE can be associated with it. True. Next, there are many flat reddish tan vegetations. There are vegetations spreading over the mitral and the chordae. The point about Libman-Sacks endocarditis is the vegetations occur on both the sides of the heart wall, the upper surface as well as the lower surface. They are more common on the lower surface, but they occur on both. They occur on both sides. That is option C. Frequently embolize. This is false. So the answer to question 128 is D. That is, they frequently embolize. This is false. This is false. On the other hand, frequent embolizations, they are associated with infective endocarditis. Frequent embolizations, they are associated with vegetations of infective endocarditis, which shows the presence of large friable vegetations. Friable means they can break off and embolize to distant sites. Infective endocarditis and of NBTE, non-bacterial thrombotic endocarditis. Frequent embolizations, they are associated with infective endocarditis and non-bacterial thrombotic endocarditis. They are not associated with Libman-Sacks. Next, this gets us to the next question, that is question number 129, which is the guardian gene. Guardian of the genome, P53. Governor of the genome, RB gene. So easy question. Question 129. The answer is A, that is P53. Easy, start one. We have already seen this in the extensive discussion. So just one statement. Guardian of the genome or molecular policeman of the genome. Guardian or molecular policeman of the genome is P53. It is P53, present on chromosome 17. Present on chromosome 17. Short arm or long arm? Short arm, chromosome 17p, versus governor of the genome, which is RB gene, retinoblastoma gene, RB gene, present on chromosome 13, 13q, that is chromosome 13 long arm, chromosome 13 long arm. Next point, an additional question that can also be asked is new molecular policeman of the genome. Please note, if molecular policeman is being asked, you will mark it as P53 only, whereas the new molecular policeman is P10. New molecular policeman of the genome, P10. This is from your latest Robbins. This is important. Next, this gets us to the next question, that is question number 130. This gets us to question number 130. T-cell tropic, the T-cell line tropic strains of HIV bind to CXCR. The answer is B, that is, they bind to CXCR, the T cell tropic genes. So let us see the pathogenesis of HIV. Let us see the pathogenesis of HIV in much more detail. Pretty commonly asked, pathogenesis of HIV. Now in HIV, the viral GP120, see on the virus, there are two regions, GP120 and GP41. GP120 is the one which is protruding out, and that is the one which first binds to CD4, leading to binding with its co-receptors, that is CXCR4 and CCR5. I'll repeat, GP120 binds first to CD4, then to its co-receptors. Next point, this in turn leads to a conformational changes in GP41, as a result of which the viral genome enters the cell. So let us write this. Viral GP120, it binds to the host CD4 receptors. It binds to the host CD4 receptors. Where are they present? On the T cells. On the T cells, it also binds to macrophages and dendritic cells. So viral GP120, it binds to the CD4 receptors on T cells, macrophages and dendritic cells. This leads to binding to the co-receptors. This leads to binding to the co-receptor molecules. And there are two co-receptor molecules which are CCR5 and CXCR4. CCR5 and, just a sec, there's slight technical thing, let's enlarge this, CCR5 and CXCR4. CCR5, the R5 strains of the virus use this. This is for the R5 strains, and this is M-tropic. M-tropic means it preferentially infects. Macrophages and monocytes. It is M-tropic. So R5 strains use it. It is M-tropic and is seen in early infections. This is the CCR5 strain versus CXCR4. The X4 strains use this. It is for the X4 strains. It is T-tropic. That is, it preferentially infects the T cells and is seen in late infection. This is binding to the co-receptors CCR5 and CXCR4. Next point. So we have seen that viral GP120 was the first one to bind, leading to binding to co-receptors. This in turn leads to exposure of GP141. Causing fusion of the virus. With host cells. Once the virus fuses with the host cells, there is uncoating of viral genome. Reverse transcriptase activity. Virus assembly, integration with host genome, virus assembly and replication. I am not much interested in these steps. The main steps that I was very interested ones were the initial 2-3 steps. Next point, Next point, this gets us to the next important point in HIV, that is the reservoirs in HIV. Now that we are doing the pathogenesis, the reservoirs in HIV, they are the follicular dendritic cells. Extremely important, reservoirs in HIV, they are the follicular dendritic cells. Where are they present? In germinal centers, present in germinal centers of lymph nodes, present in the germinal centers of lymph nodes. They are the follicular dendritic cells. These are the reservoirs of HIV. Next, this gets us to the numerous one-line questions associated with HIV. The most common fungal infection in HIV, most common fungal infection in HIV is Candida. The most common fungal infection in HIV, Candida. What is the most common site of candidiasis? Let us write it again. The most common fungal infection, the most common fungal infection in HIV, Candida, and the most common site of candidiasis is oral cavity, vagina and esophagus. Oral cavity, vagina and esophagus. This is the most common fungal infection. Next point, if the CD4 count is massively reduced, that is a CD4 count less than 50 cells per microliter, if it is massively reduced, it is associated with CMV retinitis, cytomegalovirus. It is associated with CMV retinitis. This point again is asked. Next point, the most common malignancy in AIDS is Kaposi sarcoma. Most common malignancy, Kaposi sarcoma. Associated with which virus? Associated with HHV8. Associated with HHV8. So I can rephrase this question as HHV8 is associated with, one is obviously Kaposi sarcoma. Next, it is also associated with primary effusion lymphoma, also associated with primary effusion lymphomas and Castleman disease. These are the malignancies associated with HHV8, Kaposi sarcoma, primary effusion lymphoma and Castleman disease. Next point, let us keep this as the last one in HIV. The most common CNS mass lesion. The most common CNS mass lesion in HIV is Toxoplasma gondii. The most common CNS mass lesion in HIV is Toxoplasma gondii, that is toxoplasmosis. Next, I am not writing this. The most common hematological abnormality in HIV, anemia. Most common hematological abnormality, anemia, whereas the most common lymphoma is DLBCL. You know that. Done. So this gets us to the next question, that is question number 131. This gets us to the next question, that is question 131. Which of the following is true regarding Western blot? Western blot is used for protein detection. It is gel electrophoresis of proteins. So the answer is A, that is gel electrophoresis of proteins. Gel electrophoresis of proteins. So let us have a look at the various blots. Southern blot is for DNA. Southern blot is for DNA. It's easy to remember. South India, DOSA. Southern blot, DNA. Northern blot is for RNA, whereas Western blot is for proteins. So South DOSA, Southern blot DNA, Northern blot RNA, Western blot proteins. Easy, plain and simple, easy. This gets us to the next question, that is question number 132. This gets us to the next one, that is question 132. Endothelial molecule involved in transmigration of cells in response to inflammatory stimulus is ICAM1. Transmigration of cells, ICAM1. So let us make this table. So the answer is 132, ICAM1. So this gets us to the master table of this. You very well know, plus we have already discussed it in this paper already, the steps of inflammation. There is vasodilation. So the leukocytes come to the margin of the vessel wall, margination, followed by rolling, followed by adhesion. This in turn leads to pavementing of the leukocytes, rolling, adhesion, pavementing, diapedesis. They come out of the vessel, chemotaxis. They go to the site of inflammation, that is chemotaxis, recognition of the microbe, phagocytosis and killing. These are the steps in inflammation. So how does it occur? Rolling means that the leukocytes are rolling on endothelial cells. So a leukocyte receptor will attach with endothelial receptor. So what are the leukocyte and the endothelial receptors? Let us make a table for the same. Leukocyte receptor and endothelial receptor. Leukocyte receptor, endothelial receptor. Starting with rolling. The leukocyte receptor for rolling is sialyl Lewis-X glycoprotein. The leukocyte receptor is sialyl Lewis-X glycoprotein, which binds to selectins present on endothelial cells. When rolling is taking place, it converts low affinity integrins to high affinity integrins. It converts low affinity integrins to high affinity integrins. As a result, adhesion takes place. Because of the binding of high affinity integrins with integrin ligands. Adhesion takes place because of the binding of high affinity integrins with integrin ligands. Next point, selectins. Let us see this slightly in more detail. Selectins, they are of three types. That is P selectins, which are present on platelets and endothelial cells. P selectins, which are present on platelets and endothelial cells. L selectins, which are present on leukocytes, and the last is E selectins, which are present on endothelial cells. So selectins, they are of three types: P selectins, L selectins and E selectins. Which plays the most important role in inflammation? E selectins. Which is the main acute hallmark of acute inflammation? E selectins. So I can safely say this is the hallmark of acute inflammation, that is E selectins. Next point, coming to integrin ligands. This gets us to the integrin ligands. I can divide the integrin ligands into two types. I can divide the integrin ligands into two types, which are ICAM1 and VCAM1. ICAM1 and VCAM1. ICAM1, this is the CD11A slash CD18 family of integrins. CD11A slash CD18 integrin, which is responsible for adhesion. Adhesion, we have already seen integrin ligands, they help in adhesion, transmigration, adhesion and transmigration, versus VCAM1, which is a VLA4 integrin, which helps only in adhesion. So please note, ICAM1 is also responsible for transmigration, and this was what was asked. Next point, which is the main mediator for diabetes? CD31 or PCAM. PCAM is platelet endothelial cell adhesion molecule. CD31 or PCAM. Next, this gets us to the next question, that is question number 133. This gets us to the next question, that is 133. Protein in GBM responsible for charge dependent filtration. Which protein in the GBM gives a negative charge to the GBM? Heparin sulfate, and heparin sulfate is a proteoglycan. So question number 133, the answer is C, that is proteoglycan. You very well know this. Which protein? Heparin sulfate. It gives a negative charge to the GBM. So which protein is responsible for charge dependent filtration? Heparin sulfate, which is a proteoglycan. So what do we mean by this charge dependent filtration? Albumin is negatively charged, so it is repelled by the heparin sulfate, so as a result it is not normally present in urine. Another point that we see here is anionic antigen antibody complexes. Anionic antigen antibody complexes. Anionic means negatively charged. GBM repels them, so they are subendothelial in nature. They are not able to cross the GBM. They are usually a subendothelial deposit, versus cationic antigen antibody complexes, which cross the GBM and are most commonly a subepithelial deposit. The last point is neutral antigen antibody complexes. Neutral antigen antibody complexes, which are mesangial in nature, that is, they are mesangial deposits. Done. This gets us to the next question, that is question number 134. This gets us to the next one, that is question 134. All of the following are suggestive of active disease in lupus, except, see, even if you did not know anything about this question, the answer was obvious. How? The minute I read endocapillary hypercellularity, something is proliferating, leukocytes are coming, formation of cellular crescents, these are all the features of active disease. Interstitial fibrosis, on the other hand, is a chronic long term. So the answer to question 134 is D, that is interstitial fibrosis. Interstitial fibrosis. Let us see this in more detail. So starting with lupus nephritis, let us see its main points and then we go on to the acute and the active and the chronic parts. Starting with lupus nephritis, it has 6 classes, class 1 to class 6. Most common class of lupus, most common class 4, most common class 4, also called as diffuse lupus nephritis, also called as diffuse lupus nephritis. The most common site of deposit in class 4, it has a subendothelial deposit. Most common site of deposit, subendothelial, and microscopically it is associated with the presence of wire loop lesions. Microscopically it is associated with the presence of wire loop lesions. This is class 4, diffuse lupus nephritis. Next, class 5 lupus. Class 5 lupus, this is called as the membranous lupus nephritis. Membranous lupus nephritis. Most common site of deposit being a subepithelial deposit. Most common site of deposit being a subepithelial deposit. Next point, initial site of deposit in lupus. Initial site of deposit in lupus, the first site of deposit or the initial site of deposit in lupus, this would be class 1 and class 2 lupus nephritis, which is associated with mesangial deposits. Initial site of deposit in lupus, this is the class 1 and the class 2 deposit, which are mesangial in nature. Next point, so this gets us to the lesions indicative of acute and chronic disease. Lesions indicative of, this gets us to the lesions indicative of activity of the disease. Indicative of activity of the disease. I can divide the lesions into active lupus nephritis. I can divide the lesions into active lupus nephritis and chronic lupus nephritis. Into active and chronic lupus nephritis. Active lupus nephritis, it is associated with endocapillary hypercellularity. It is associated with endocapillary hypercellularity. Endocapillary hypercellularity, leukocyte infiltration, leukocyte infiltration, subendothelial deposits or a subendothelial hyaline material, fibrinoid necrosis. You very well know fibrinoid necrosis, it is more aggressive in nature. Fibrinoid necrosis, cellular crescents or interstitial inflammation. Interstitial inflammation. This is active lupus nephritis. Easy. Something is proliferating, leukocytes are coming in, subendothelial gland deposit, fibrinoid necrosis is as such more aggressive in nature, cellular crescents or interstitial inflammation. Versus chronicity, which is by glomerulosclerosis, presence of fibrous crescents. Please note, cellular crescents is active, fibrous crescents is chronic. Presence of fibrous crescents. Tubular atrophy and interstitial fibrosis. This is chronicity. In lupus nephritis. done. So in the paper what was asked was interstitial fibrosis, which is a feature of chronic and not acute. Next, this gets us to the next question, that is question number 135. This gets us to the next question, that is question 135. Wrong statement in inherited syndromes is majority are inherited as autosomal dominant. This is true. This is true. You can take almost any, that is HNPCC, FAB, it is all autosomal dominant. FAB is a dominantly inherited colon cancer syndrome due to germline mutations in APC present on chromosome 5. This again is true. Most HNPC cases, HNPCC is one of the 4 DNA mismatch repair genes. True. Most cells of individuals with inherited loss of function mutation in a tumor suppressor gene are functionally abnormal. This is false. Only the cells which are leukemic are functionally abnormal. The statement is saying most cells of an individual with loss of function mutation are abnormal. It is not most of the cells, it is only the leukemic cells, the ones which have the loss of function mutation, which are abnormal. So question number 135, the answer is D, that is most cells of an individual with loss of function mutation are functionally abnormal. This is false. This is false. It is not most of the cells. So what we see here is the tumor ensure a loss of remaining normal allele in agreement with the two-hit hypothesis. So let me rephrase this as let us see it option wise. Starting with the first option, we have already seen that the most cell part was wrong. It was the cells which are leukemic. Next, starting with the option wise, FAP, familial adenomatous polyposis, associated with mutation in APC gene mutation present on chromosome 5. Next point, FAP, familial adenomatous polyposis, the risk of malignancy in FAP is 100%. Risk of malignancy is 100%. That means all the patients of FAP will progress to adenocarcinoma. All patients will progress to adenocarcinoma. When? At a young age or older age? At a younger age, that is less than 30 years of age. These were the main points with FAP. I am not getting into the syndromes associated, that is, it is associated with 2 syndromes, Gardner's and Turcotte's. Not getting into that. So this was FAP. Next option was, one of the options was HNPCC. Both FAP and HNPCC, both of these, they are autosomal dominant in nature. And HNPCC, this occurs only because of mutations in the MSI pathway. MSI stands for microsatellite. MSI stands for microsatellite instability pathway. Microsatellite instability pathway, also called as DNA mismatch repair pathway. Also called as DNA mismatch repair pathway. So FAP, this occurs because of mutations in MSI, microsatellite instability, or the DNA mismatch repair pathway, in which the names of the mutations, the names of the gene mutations, they start with M, that is MUTYH, MSH2, MSH6, MLH1. See, you need not remember them. Options will be there in front of you. MSI pathway, the genes involved, they start with M. MUTYH, MSH2, MSH6, MLH1, PMS1 and PMS2. except PMS 1 and 2, all others they start with M. Next, this gets us to the next question, that is question number 136. This gets us to the next question 136. Sapporo investigation criteria. Sapporo investigation criteria, it is used for APLA, antiphospholipid antibody syndrome. The answer is C, that is it is used for APLA. It is used for APLA, antiphospholipid antibody syndrome. So before we go further, let us have a look at what are the Sapporo investigations criteria. APLA, you very well know, antiphospholipid antibody. It is associated with anti-cardiolipin antibodies. Next point, antiphospholipid serine antibodies are also positive, and it gives a false positive for syphilis. You know that. So sticking to the question, APLA, let us see the Sapporo investigational criteria. The Sapporo investigational criteria for APLA. What it says is the first set of criterias are the clinical ones. Clinically, it is associated with vascular thrombosis. Clinically, it is associated with vascular thrombosis, where that is one or more episodes. What do we mean by this? One or more episodes of arterial, venous or small vessel thrombosis. Arterial, venous or small vessel thrombosis. So clinically it is associated with vascular thrombosis. Next, it is also associated with morbidity in pregnancy. Morbidity in pregnancy. You very well know this, that APLA as such increases the risk of abortions in females. So morbidity in pregnancy. The lab criteria, so clinical was vascular thrombosis and pregnancy morbidity. The lab criteria are anti-cardiolipin antibody, presence of anti-cardiolipin antibody, and lupus anticoagulant in plasma. Lupus anticoagulant in plasma. I am not getting into the time periods, how far away, how many times and stuff. Not needed. Simple. Sapporo investigation criteria, clinical and lab criteria. It is said to be lupus when one clinical or one lab criteria is present. One clinical and one lab criteria is present. This is Sapporo's investigational criteria for APLA. Next, this gets us to the next question, that is question number 137. This gets us to the next one, question 137. Following image shows a kidney lesion in the adult. Now let us have a look at the kidney lesion. What it is showing you, even if adult was not mentioned, have a look at the kidney. It is showing you the presence of cysts with the bosselated outer surface. Bosselated outer surface is seen in adult polycystic kidney disease versus the smooth outer surface of the kidney, which is in childhood polycystic kidney disease. This is showing you a bosselated outer surface. So this is adult PKD. In the question also adult is mentioned. Even if that was not mentioned, the diagnosis just by the image was adult polycystic kidney disease. It is autosomal dominant, not autosomal recessive. It is autosomal dominant. Renal failure and azotemia is the commonest presentation. Not at all. Renal failure develops in 5th to 6th decade of life. Increased diastolic BP is one of the earliest signs. This is true. PET-CT is the investigation of choice. No, it is ultrasound. So the answer is C. The answer is C. That is, increased diastolic BP? The answer is C, that is increased diastolic BP is one of the earliest signs. Increased diastolic BP is one of the earliest signs. So let us see few features with adult polycystic kidney disease. Adult PKD. First point, grossly we have already seen that grossly it shows the presence of a bosselated outer surface. It shows the presence of bosselated outer surface. Bosselated means these are the bossellations versus the smooth outer surface of childhood PKD. This is what a smooth surface looks like. Smooth outer surface of childhood PKD. Next point. So the first gross feature was bosselated outer surface, making it as adult PKD, and the second gross feature is cut section. In adult PKD, the cysts are randomly distributed. The cysts are randomly distributed in cortex and medulla. In adult PKD, the cysts are randomly distributed in cortex and medulla versus childhood PKD, where the cysts are present at right angles to the renal capsule. Next point, adult PKD, the chromosomes involved are 16 and 4, which involves the gene PKD1 and PKD2 eliciting the protein polycystin. So you know polycystin. So you know the genes involved, you know the chromosome, you know the protein. Next point, extremely important, it is bilateral in nature, has been repeatedly asked. Next, it is a progressive renal disease. Progressive means it is a progressive renal disease. Progressive means it leads to the development of chronic renal failure in 5th to 6th decade of life. It is not the presenting complaint. It leads to chronic renal failure in 5th to 6th decade. Next point, it is autosomal dominant in nature, not autosomal recessive. Childhood polycystic kidney disease is autosomal recessive. This is autosomal dominant in nature. Done. Last point, ultrasound. The technique of choice, the investigation of choice radiologically is ultrasound. It is not PET CT or anything else. It is ultrasound. Next point. Next, this gets us to the next question, that is question 138. This gets us to the next question, that is question number 138. First point, let us have a look at this. Sherman's paradox applies to which disease? We have already seen this in detail, Fragile X syndrome. Sherman paradox, it is associated with trinucleotide repeat disease. Fragile X syndrome, it is a trinucleotide repeat disease. We have seen this. Which trinucleotides are getting repeated in Fragile X? CGG. Easy to remember, Fragile X associated with mental retardation. Patient has Kam Gyan. So the trinucleotides are Kam Gyan, CGG. What was Sherman's paradox? It was another name for anticipation. We have done this in detail. Anticipation is with successive generations there is increasing severity of the disease. That is, the mutation increases at oogenesis. This occurs because the mutation increases at oogenesis. This is just a repeat. This is a repeat of what we have already discussed, Sherman's paradox. Next, this gets us to the next question, that is question number 139. This gets us to the next one, that is question 139. 56 male, severe chest pain, lab shows serum troponin I is increased, coronary angiogram more than 90% in occlusion. In this setting, irreversible injury has occurred by which change? So all the examiner is asking you is, he has given a long history, everything, but his question is very simple. Irreversible damage or irreversible injury is associated with nuclei undergoing karyodesis. Option C, irreversible damage, it is associated with nuclei undergoing karyodesis. Nuclei undergoing karyodesis. This is irreversible damage which is seen in a cell. This is a feature of irreversible damage. So before we go further, let us see the changes associated with reversible and irreversible cell injury. Starting with reversible cell injury. Reversible injury, it is associated with cellular swelling. Reversible injury, it is associated with cellular swelling, which is the first change or the first manifestation. Cellular swelling, this is the first manifestation. Other changes in reversible change are plasma membrane changes, cellular swelling. Next, plasma membrane alterations, that is blebbing, blunting, and loss of microvilli. Blebbing, blunting, and loss of microvilli. These are the plasma membrane alterations. Next, mitochondrial changes. That is mitochondrial swelling and small amorphous densities in mitochondria. Mitochondrial swelling and small amorphous densities. Please note, small amorphous densities is reversible, large amorphous densities is irreversible. Next, the other changes are dilatation of endoplasmic reticulum. With detachment of polysomes. Dilatation of endoplasmic reticulum with detachment of polysomes and nuclear alterations. And the last set being nuclear alterations. What are the nuclear alterations? It is associated with disaggregation of granules. Disaggregation of granules and fibrillary elements. कुछ नहीं है, it is extremely easy. The first manifestation was cellular swelling. Others are plasma membrane changes, blebbing, blunting, and loss of microvilli, mitochondrial swelling, and small amorphous densities. It is not large, it is small amorphous densities, dilatation of endoplasmic reticulum, and detachment of polysomes, and the nuclear alterations. All these are reversible changes versus irreversible changes. Which was asked in the paper. Irreversible changes, which are the mitochondrial changes, mitochondrial changes which is associated with severe swelling. Mitochondrial changes, that is severe swelling, and the presence of large amorphous flocculent densities in mitochondria. So please note, small amorphous densities is reversible, large is irreversible. The next set of changes are the nuclear changes, where it is associated with pycnosis, that is nuclear shrinkage, karyolysis, that is dissolution of the nucleus, and karyorexis, that is fragmentation of the nucleus. So nuclear changes: pycnosis, karyolysis, and karyorexis. And lastly, the last set of changes in irreversible damages: eosinophilia increases, basophilia reduces. Why? What is blue in a cell? Nucleus. If nucleus is undergoing pycnosis, karyorexis, and karyolysis, basophilia reduces, eosinophilia increases. Done. This finishes question 139. So this gets us to the next question, that is question 140. This gets us to the next one, that is 140. So answer to 139, nuclei undergoing karyorexis. Question 140. What we have here is CSF electrophoresis of a patient shows oligoclonal bands. Which of the following is associated? The minute we see this was normal, minute we see oligoclonal bands, that is the bands are less, it is associated only with one disease, that is multiple sclerosis. The answer is C, that is multiple sclerosis. This is a factual question and has to be remembered, associated with the presence of oligoclonal bands in CSF. इसमें do not overthink it, do not use your mind, do not go for the revised Donald's criteria, nothing, absolutely nothing. Oligoclonal bands, multiple sclerosis. Next, this gets us to the next question, that is question 141. Question 141. 59 male loss of consciousness for an hour, could not move hand or leg. Months later, 5 cm cystic area. For which of the following cellular events? Long history, a lot of crap is given. All the examiner was asking you was only one point. Ischemic related damage to the brain is associated with liquefactive necrosis. The answer is A, that is liquefactive necrosis. See, whenever you are solving any question, do not go by the complexity of the question, you have to come to the crux of it. So all the examiner was asking you was ischemic injuries generally are associated with coagulative necrosis. I need not even write this, you know it very well. Except in the brain where it is associated with liquefactive necrosis. This was all that was needed in this. This was all. Next, this gets us to the next question, that is question 142. This gets us to the next one, that is question number 142. 22-year female, congenital anemia, multiple transfusions of RBCs. Multiple transfusions. Now, see, whenever a history of multiple transfusions is given, always think of multiple transfusions are associated with iron overload. What you have here is the classical liver biopsy. This, if nothing else was given, just this image was given. Let me slightly enlarge it. If only this image was given, it shows the presence, it's a pulse stain. pearls or a Prussian blue stain which shows the presence of hepatocytes with these dark blue areas, which is iron accumulation, that is hemosiderin. So in this question, no history is needed, nothing is needed, just the image. This shows hemosiderosis. So the answer is hemosiderin in hepatocytes. The answer is C, that is hemosiderin in hepatocytes. Hemosiderin in hepatocytes. So what we have here is, let us see few features of hemosiderosis, starting with microscopy. Which stain do we use for hemosiderin? The stain used is the Prussian blue stain. The stain used is the Prussian blue or the pearl stain. That was what was given. Next point, inheritance pattern. Hemosiderosis, it is an autosomal recessive condition. It is an autosomal recessive disease. The test for which, before we go to that, which is the most common mutation? Most common mutation in hemochromatosis is the HFE gene mutation. HFE gene mutation present on chromosome 6. So when there is more than 20 grams of stored iron. Every year there is net accumulation of 0.5 to 1 gram iron per year. Normal body iron in males is 6 grams, females is 2.5 grams. So when will the disease manifest earlier, in males or females? Males more than females. Next point, this gets us to the tests for hemosiderosis. First point, the best screening test is serum transferrin saturation. The best screening test is serum transferrin saturation, because the transferrin saturation, it increases with increased iron. So hemochromatosis, serum transferrin. Whereas the diagnostic gold standard is quantitative assessment. The diagnostic gold standard is quantitative assessment of tissue iron. Quantitative assessment of tissue iron. Next point, however, the test of choice is genetic testing. These are the tests used in hemochromatosis. We have already seen the stain is pearls or the Prussian blue stain. So multiple blood transfusions, iron overload, hemochromatosis, autosomal recessive, HFE gene, chromosome 6. These are the main points with hemochromatosis. We have already seen its microscopy. Next, this gets us to the next question, that is question 143. This gets us to the next question, that is question number 143. First point, let us have a look at the question. In an experiment, a tissue preparation is subjected to oxygen stress, increased free radicals. It is the most likely protective mechanism to reduce the free radicals is glutathione peroxidase. I guess nothing to explain in this. Question 143. The answer is A, that is glutathione peroxidase. Glutathione peroxidase. You very well know glutathione peroxidase in presence of free radicals. In presence of free radicals, it is an antioxidant. That is, the reduced form of glutathione peroxidase, reduced glutathione, is converted to the oxidized form. It is converted to the oxidized form, and when this is occurring, it converts H2O2 to H2O plus O2. It is an antioxidant. It is an antioxidant. So for scavenging the free radicals or an antioxidant change, it is glutathione peroxidase. Next.